Hello everyone, my name is Deawodi Ladzekpo. I'm a third-year combined pediatric emergency medicine and clinical informatics fellow at Cincinnati Children's Hospital. Now, let's jump into our case. Our patient is a 3-month-old male presenting with increased work of breathing. The day prior to presentation, his mother reported significant congestion and that the patient was being sectioned every 2 hours with saline without much relief. He presented to his PCP office that day in the morning for increased work of breathing. He was also noted to have stridor on exam at the PCP's office and received dexamethasone. Of note, mother says he has had noisy breathing since birth and felt it was unchanged from baseline. He already had an appointment scheduled to see ENT the next week. However, because of persistent increased work of breathing, the PCP referred him to the emergency department to be seen. On his review of systems, he was noted to have no vomiting or diarrhea, no sweating, choking, or color change with feeds. He also had a normal urine and stool output. However, review of systems was positive for weight loss, and the family had just within the week recently started supplementing feeds, and he had been tolerating that well. In terms of his birth history, the patient was born at 41 weeks and 0 days to a 28-year-old female via spontaneous vaginal delivery. The pregnancy and delivery were both uncomplicated. He received vitamin K and hepatitis B vaccine as well as erythromycin ointment in the nursery. He also passed the congenital heart disease screen, but failed the hearing screen on the left ear. His birth weight was 2756 grams, which is 6 pounds and 1.2 ounces. His discharge weight was 2626 grams, which was 5% down from his birth weight. This was the patient's growth chart at time of presentation to the emergency department. His weight at the time was 4.39 kilos, which was significantly below the first percentile for age, as seen here on this growth chart. On physical exam, the patient's vitals were as follows: temperature of 38.2 degrees Celsius, pulse of 185, respiratory rate of 66, and oxygen saturation of 98%. He was noted to be alert and playful, yet thin appearing. His HENT exam was notable for normal tympanic membranes. He had some dried rhinorrhea, not copious, and intermittent nasal flaring. His respiratory exam was notable for pan retractions with visible ribs, lungs with intermittent crackles, no wheezing, and a mild pectus excavatum. On his abdominal exam, the belly was noted to be soft, non-distended, non-tender to palpation in all 4 quadrants without hepatosplenomegaly. He had a normal GU exam, and on his musculoskeletal exam, he was noted to have decreased bulk. Neurologic-wise, he was moving all extremities appropriately with normal tone. His skin was noted to be warm, well perfused, without any rashes. In the emergency department, the patient was suctioned with moderate thick secretions and received acetaminophen for his fever. After these interventions, he only had mild improvement in his retractions, but did have a decrease in his respirations to the 40s, and his heart rate reduced to the 160s. He also had mild improvement in his lung exam with no crackles heard. The decision was made to admit the patient to hospital medicine for further management of failure to thrive and viral respiratory infection. Hope to see you in part 2 as we discuss the differentials and discuss the final diagnosis.